The COVID-19 pandemic has shown us just how important vaccines can be in saving lives. That's why C.A.R.P presents this free online educational event. Hear from experts and make informed decisions that will help you stay safe this winter and the coming year. Joining us live from the Zoomer Media Studios in Toronto is Natasha Raey. The C.A.R.P National Vaccine Summit Part 2 begins now.
Good morning and welcome to the National Vaccine Summit Part 2, presented by C.A.R.P, A New Vision of Aging. I'm Natasha Raey, live from Zoomer Hall. Like many of you, vaccinations for COVID and beyond have been top of mind for me. And with the flu season upon us, there are a number of questions we all have around COVID, flu shots, and the other vaccines we need along our lifespan. Stay tuned to this screen today as we connect with experts around the country on vaccines and the role that they can play in your health and the health of your family. But first, C.A.R.P members will know our first speaker today. Bill VanGorder is Chief Policy Officer and Chief Operating Officer for C.A.R.P and was the founding chair of the Nova Scotia chapter. He is also the immediate past chair of the Nova Scotia Advisory Committee on Seniors Issues to the provincial government. Bill joins us from Halifax to talk about the importance of staying up to date on adult vaccinations. Welcome, Bill.
Hello, everyone. I'm Bill VanGorder, Chief Policy Officer and Chief Operating Officer of C.A.R.P, A New Vision of Aging. It's great to see such a large turnout for a subject that's so near to my heart. We're hosting the summit today to bring awareness and urgency to the issue of adult vaccinations. You know, the Public Health Agency of Canada has previously reported that less than 10% of older adults are fully up to date on their vaccines. But a follow-up survey to individuals showed that number could even be closer to 3%. Well, we can and we must do better. As we grow older, our immune systems evolve and our body's ability to fight off infections deteriorates. Whether COVID-19, influenza, shingles, or pneumonia, this decline of the immune system, coupled with underlying conditions, increases the risk of severe complications and even death. Well, often the reason is budgets over health. For example, no province currently covers the new highly effective vaccine Shingrix, which protects against debilitating shingles virus. But others, it's an underestimation of the seriousness of the illness, as can be the case with pneumonia. And not to mention the difficulty of tracking down one's own immunization record. That can be tedious. But staying up to date on our routine and recommended vaccinations is so essential. Now more than ever, older adults are hyper concerned about any other potential weakening of their immune systems and want a fighting chance if they contract COVID-19. So that's why access and funding for best-in-class vaccines to combat seasonal influenza, pneumonia, and shingles in older adults is so vitally important. Now, in today's program, you'll hear from some of the best in the field on why we cannot let our guard down during the flu season, the importance of being vaccinated against both COVID-19 and the flu. We'll address vaccine hesitancy and other concerns of C.A.R.P members, and why protecting against pneumonia and shingles through vaccination is so critical for older adults. As always, C.A.R.P has your back and will continue to fight for you every step of the way. Back to you, Natasha.
Thanks, Bill. Our next speaker is Dr. Birinder Narang, a family physician at Reach Community Health Centre in Burnaby, British Columbia. Dr. Narang is on the steering committee of the South Asian COVID Task Force and is a founding member of the This Is Our Shot Vaccine Confidence campaign. Welcome, Birinder. Thank you for joining us today.
Thanks for having me. Good morning.
Thank you. So I'm going to start with a question that has been on all of our minds. Why is it important for people to get the flu shot, even if you're already vaccinated against COVID?
Yeah, so it's a lot of question that we're being asked a lot this year, and I think it's important to remember that getting the influenza virus and the COVID-19 virus, they're caused by two different viruses. So there's a SARS-CoV-2 virus, which causes COVID, and then there's multiple influenza viruses that can cause influenza. And so if you get vaccine for one, it's not going to protect you against the other. And it's important to realize that initially, if you get symptoms, you can't really tell which one you're getting. And so by getting your influenza vaccine early, you can not only protect yourself, protect people around you, but also make sure that you're helping to keep that pressure off the healthcare system, where we know that there's already so much strain.
And you mentioned getting the flu vaccine early. So I've been reading in a number of articles that they've been recommending that people get their flu vaccine by the middle of December. So is this true for Canadians? And is that sort of when we're expecting to see the most flu cases?
So generally, I haven't read the December thing myself, but why I think they may be saying that is because the peak of the flu season generally is around that December to February time range. Although it generally lasts, the entire flu season is usually around November to April. And so what we do know is once you get your vaccine for influenza, it takes a couple of weeks for you to actually build that antibody response to have that protection. So I imagine why they're saying that is so that you're ready for the peak of the season. But we've been giving vaccines since October, and I would just encourage people to get it as soon as possible. We're already into December now, so even if you get it now, you'll get your protection just before Christmas.
And as a family physician, you understand the importance of your patients speaking to you before they start any sort of new treatment or medical medication. So with the flu shot, are there any specific populations of patients who should be speaking to their family physician before getting a flu shot?
Yeah, so, as I think about that, I also think about who are the populations that absolutely should get it who are inherently at higher risk. And so I'm thinking about people, young children, people who are pregnant, those are elderly, certain like lung, kidney, heart diseases. And those who are able to transmit the influenza virus, so those who live at high risk, so who are the vulnerable people with us, and people who live at communities, working essential community services with high risk populations. So those are the people who absolutely should get it. Now, people who have traditionally had concerns about vaccines, there's a few subpopulations. So there are people who are pregnant. You should definitely not be getting any type of live vaccine. And that's generally a principle that we carry against all vaccinations. And NACI, our National Advisory Committee on Immunization, has put out strong guidance that, even me coming through medical school, I was taught if you have a severe egg allergy, you should avoid the influenza virus. But that has been disproven now. There's lots of evidence that it's safe, even if you have anaphylaxis to egg product. It's safe to get the influenza vaccine. The last one I want to mention is there's a certain syndrome that's called Guillain-Barré syndrome, which is like when your immune system goes into overdrive and starts attacking some of the peripheral nerves in your body. And so people, if you've previously developed Guillain-Barré syndrome within 8 weeks of getting a previous dose of an influenza vaccine, then it's best to avoid it. So if you have any of those concerns, definitely speak with your family physician.
Great. And can you explain, how does the flu shot actually work? And will it protect us 100% from getting the flu?
Well, I would just say it's magic, and then we'll leave it at that. No, it's all vaccines.
You're going to have to tell us a little bit more than that, Dr. Narang.
So, seriously speaking, so what is our immune system always doing? Essentially, it's looking for kind of foreign invaders in our body, and those are kind of germs or like something that the body doesn't recognize as a safe space. And so that's essentially what the whole principle about vaccination is. Now, there are different types of influenza vaccines. Like I already mentioned, there's a live attenuated vaccine, which most commonly is available as the flu mist nasal spray, indicated for most children. That and 2 to 17, that's a live vaccine. And so that is a weakened, or what attenuated just means weakened version of the vaccine, which your body will recognize as foreign and will then stimulate your immune response. But most of the vaccines that we use are actually not live vaccines. They're inactivated vaccines, which means that they're killed. So they're killed vaccines. Your body will still recognize them as foreign and will stimulate that response. Now, there is no vaccine that will give us 100% protection. And so the effectiveness of the flu vaccine for this year, we're not going to find out for a couple of months from now, because the preparation of the vaccine changes every year, and it goes based on what is happening in the rest of the world. So we know that the influenza virus is predominantly related to travel. So what we look at what's happening in the southern hemisphere, what are the strains that were circulating them in the previous flu season, and because of generally open travel, which we'll get back to not necessarily being the case in the past couple of years, that is the strain that they can transmit to the northern hemisphere. So we generally are pretty good at predicting what strains will be around, and if it's a well-matched vaccine, which a lot of the time it is, it can give you up to 60 to 80% protection.
So I want to touch on two of the points you mentioned. So one of them was that the influenza virus and the spreading is affected by open travel. So one of the things I kept hearing last year was, well, the flu disappeared because of COVID. So why are people saying this? Is it partly because we weren't traveling like we have been in previous years? And also, my opinion is because people started washing their hands and wearing masks. So what's your medical opinion about why people are saying the flu disappeared last year?
Yeah, I mean, I guess it's a terrifying thought of how much people might not have been washing their hands before. But yeah, so I'm in BC, as we said. There was only one case of the influenza virus in BC last year. And when we look around at it nationally, in the 2021 Canadian influenza season, there were only 69 cases. And that percent positivity, so like the chance of testing positive, was 0.1%. Now, I wish we could get COVID to that, but you're absolutely right. Travel bans, or the travel bans that existed last year, was a huge part of that. There were also regional stay-at-home orders. All the stuff we've been hearing to protect ourselves from getting infected with COVID also applies to the influenza virus too, when we're talking about washing our hands, physically distancing, not going out if you're sick, wearing effective masks. So all of that helps, and that's why we were seeing a lot less of it. Now, we're seeing a bit of a change this year. I mean, we haven't seen any significant resurgence yet. I had a look last night, in BC, we've had about 123 cases in the season so far, and knowing that we're a couple of months into it now, or maybe 6 weeks or so, there have been 123 cases in BC, and when we look at it nationally, we're seeing about 20 to 40 cases nationally right now. So let's say, just looking at the last amount of data available, there are in mid-30s cases that were found. And an interesting stat that I saw, and I don't know how reproducible this is or how it will be going forward, is that 91% of those cases were in people under the age of 44. So, it's interesting, doesn't surprise me. That is a population that's going to be getting out there more, socializing more, also working in kind of frontline jobs where they might be placed at higher risk of actually contracting viruses. But definitely something to keep in mind if you're looking at your own vaccination or your household vaccination status.
So clearly there's been an increase in influenza cases from what we saw last year. So is that why there's the fear of a twindemic? So we keep hearing, get your flu shot because we don't want a twindemic. So can you first define what is a twindemic and why the flu shot is so much more important this year than it probably was last year?
Yeah, no, absolutely. And I think that there are very real concerns from it. Let's define the term. I mean, pandemic, we all know what that is. We've been living in it since March 2020. Twin is just a way of playing on the fact that there are two viruses, the influenza virus and the COVID virus, and both have potential to do some serious harm to people, especially, like we said, those that are vulnerable, because there is increased travel, there's increased mingling, there's also an increased kind of push in society to reconnect with each other right now, which, I completely encourage. It's about how do we kind of mitigate those risks as much as possible. And, we're very fortunate in Canada that we have really great vaccination uptake across the country, but it's not perfect. But when I look at the twindemic potential, I worry about our neighbors down the south. We know that even in the last week, their COVID-19 numbers and deaths have both gone up by 44%. And there's an incredible strain and burnout in the healthcare system. And influenza has definitely the potential to cause severe illness in people who have underlying conditions. So we look at the impact on the society, on the on the individual, the community, and on the healthcare system again. And definitely there is potential for both to do damage. So definitely get your influenza and your COVID vaccines.
Thank you. So we have an audience question, and this is relevant to COVID. So Dave from Halton Hills has a family member who's unvaccinated against COVID-19 and asks, is there a risk in us getting together with an unvaccinated person, or is the threat or danger really more to them because they're the unvaccinated person?
Yeah, so I think I would look at this from first principles. Like we said, there is no vaccine which is 100% protective. In saying that, the COVID vaccines that we have, and I don't know Dave's specific vaccine combination or timing or when he got it, but we know that they have been amazingly protective at severe illness. And so, I don't know what your age is. We are seeing breakthrough cases which are happening, especially in over the age 60 population. And there's a lot of evidence, even this week, that evidence that is showing how protective boosters are, and how we might even need to start thinking about this COVID-19 vaccine series as a 3-vaccine series. And so when I put that all together, the risk is not zero for you and your family, Dave, but it is much lower. But the risk is definitely higher to that unvaccinated guest. There are ways that you could mitigate it, which are not perfect. I mean, if you have access to a rapid antigen test, you could get that done prior to the gathering, just to add that extra layer of protection. Again, I don't remember where your the question came from, but depending on how the weather is, ensuring where you're doing your gathering that there's a great ventilation is important. And definitely in Canada, in some parts over Christmas, that is not feasible or practical to be doing it outside or with your windows fully open. So it's all about risk mitigation as much. And the last point with that is I would just I would see what your guest's comfort level is and what their job and activity is. Are they working in a condition where they're likely to be exposed to it? Are you living in an area where there have been a lot of community transmission? I think you have to weigh all of those things before you make that decision.
That's great advice. And just before we wrap up, you were one of the founding members of the This Is Our Shot campaign. So are there any last words or pearls of wisdom that you could give to our audience that come from the campaign, or sort of what you're trying to get out to the masses?
No, I think it was a great experience. I think on a personal level, I learned about the power of grassroots movements and how impactful they can be. What I would always encourage is, no matter how hesitant you are to whatever vaccination it is, speak to your family care family doctor. And if you don't have a family doctor, even attending an urgent care clinic or a walk-in clinic or a digital provider at this point would be a great idea. We're all trained to have these discussions. There's no judgment in the discussions. We're just here to support you and help you ease your concerns and help you make the decision that's best for you.
Amazing. Well, thank you so much, Dr. Narang. I know that was very helpful for me, very insightful, and it was wonderful speaking with you this morning. Thank you.
Have a great day. Thank you.
You as well. Our next speaker is Andy Donald. Andy is a certified geriatric pharmacist who has completed 4 university degrees, including a master's degree in cell biology at Queen's and a pharmacy degree at the U of T. Welcome, Andy. Thank you so much for joining us today.
Thanks for having me, Natasha. Nice to meet you.
Nice to meet you as well. So my first question for you, and we spoke about this, and it's something that I never thought of until I started speaking with you, is flu vaccine supply an issue this year or in any other years, and why?
It's not as different as other years. It does ebb and flow, and it kind of depends on the need as well as the distributor, but it's not very different from other seasons, no.
So in terms of the flu dose, the flu vaccine itself, the National Advisory Committee on Immunization is recommending a high-dose flu vaccine. So what is that, and what does this recommendation mean for our audience?
Sounds good. Yeah, like the high dose, it just means that you're getting 4 times more of the actual antigen, right, in the vaccine. So it just means you have a lot more, so your body can build a lot more of an immune response to it, the actual, to the virus, and it'll last a lot longer in your body. So just make sure it provides us with better, longer protection.
And so when someone goes to the pharmacy to get their vaccine, should they be asking for a high dose, or is this just something that the pharmacist will know to give them?
You should just double check. It would be good to know because there is a lower dose vaccine as well as a high dose. So it would be good to double check with the pharmacy just to ensure that you're getting it. You should ask for it.
And is there a specific age group that should be asking for this, or should it be me or my mom, or?
Yeah, it's typically, like, for sure, older adults, anyone over the age of 65 as senior,
Okay.
And any immunocompromised individuals as well, for sure. So that includes, individuals who are getting treatment for arthritis and conditions like that. It's best to speak with your doctor and your pharmacist whether or not you qualify for that, but it's definitely, there are certain age groups for sure that the older adults and health conditions that should get the higher dose, for sure.
So our last speaker, Dr. Narang, was speaking a little bit about live vaccines. And I know in our discussions you mentioned they're not really used that much anymore. So could you first define what is a live vaccine? And are the flu shots this year, are those live vaccines?
For sure. There are still a few live vaccines out there. What they're called is they're live attenuated vaccines. And so what that means is that they take the virulence out of it, the part that causes disease. So it's like a hollow virus that will allow our body to still fight it and get a good immunity with it without us getting the actual disease. But the flu shot this year and also COVID are not actually live vaccines at all. They're kind of like, it's a nice little cheat that what it does is it causes our body to get the dead, chopped up portions of the virus, or with the COVID-19 vaccine is just one spike protein that our body can fight it and develop a good immunity to it ahead of time. So when we do contact the actual real virus in day-to-day life, that we already have built up an army of immune cells to fight it off. It's a nice little cheat, so we don't actually have to risk getting the disease itself.
So then there's a belief out there that if you take the flu vaccine, you could get the flu from the vaccine because you're being injected with this. So you kind of just prove that this is not what's happening. But to the layperson, can you sort of explain like what happens then? So like when I had my COVID vaccine, and even with past flu vaccines, I felt sick afterwards. So what is that feeling? Where is it coming from? And why is it not actually the flu?
For sure. And this is why sometimes we've heard, like in pharmacy and practice, that some individuals say, I don't want to get the flu vaccine because it gave me the flu.
Right.
That is actually impossible. It doesn't actually give you the flu. What happens is that your body can be tricked into thinking it's under attack. So our body is a natural defense mechanism. For instance, certain things like if we get a fever, that is our body turning our body temperature up a little bit, because what it does then, it helps to melt the proteins in the virus so our body can fight it and kill it quicker. So that is a defense mechanism. Just like stuffy nose, runny nose is as well, because that's just us recruiting a lot of white blood cells into the area of our nose to try to quarantine and kill a virus. So if we get a lot of antigen, it's still foreign to our body. Our body will then think it's under attack and will try to recruit all of its tools to try to fight an evading organism or like a virus to try to kill it to protect us. So if you do get a fever, if you do get a runny nose and things like that after getting a shot, like the flu shot, you can still take Tylenol or Advil to help get rid of the fever, to treat your symptoms, because it's actually our body being fooled into thinking it's really in danger when it's not, really. We just need 2 weeks to build up a huge immunity for the antibodies, like as was mentioned previously. But the actual real quick symptoms we don't need for after immunization.
Okay, that makes it really clear for me. Thank you. So what is the best flu vaccine for different age groups? So we talked about high dose flu vaccines. So is there, at my age, is there a flu vaccine? We won't guess my age, but at my age, is there a specific flu vaccine that I should be getting versus one that my parents would be getting?
The important thing is there's charts on this, and you don't need to worry about it. Your pharmacist and your doctor has it all, right? So, and it's all based on really safety studies that were done by the manufacturer to test in what age groups they tested and what age groups they got approved for. So you should, your pharmacy and your doctor's office should know that, and they'll give you what you need. So it's just important to communicate with the pharmacy if you're more high risk, if you are immunocompromised, you may need a higher dose for sure.
Right.
But besides that, they know what age group, based on your age, what are the correct vaccine to give you.
And I know this is a hard question to answer on a national level, but one of the things we're hearing is that the high-dose flu vaccine is in short supply right now at some pharmacies. So is this an actual issue, and is there any solutions in the future that are going to fix this?
It's unfortunately been an issue every year. The high dose has always been quick to go out, and they're getting better. It's getting better than previous years, but it's good to follow up and to call ahead. Sometimes your pharmacy or your doctor to see if they have the high dose, to see just to double check ahead of time, right? And it changes based on availability, but it's been in a lot higher demand. And what we're learning over time, it's better for a lot more people to get the high dose. So make sure that it lasts the whole flu season, 6 months. So it's something that over time we're getting better and better at with the government, with the system, to make sure that there's more available. But it's still not perfect, but it's getting better year to year.
Right, and it's another reason why it's important to get your flu shot sooner rather than later, so you can get one of those high dose vaccines before they run out. So when we look
early bird gets warm, right?
Yeah. So when we look at effectiveness, if I go and get my flu shot today, when am I fully protected?
It'll take. I think your last guest mentioned that it was. It's about 2 weeks to get the protection, like when it really starts to kick in for sure. And then, by 3 weeks, 4 weeks, it's working great. And it should last for about 6 months, typically.
Okay. Which is good. And that's probably another reason why we are supposed to get the flu shot every year, I'm assuming.
Yes.
I kind of answered the question I was going to ask you. But
yeah, you need even if the flu didn't change, you still would need a booster every year because it does wean. But like as we mentioned, like it mutates very quickly, like COVID. And to that extent, we have to kind of guess because it takes about a year, almost a whole year to make the flu vaccine. So it's about a year ahead of time. Usually February when they start to choose the strains for making the flu shot, they start making it for the next November, right? So they have to start, and that's why some years they might say that it's 63% effective, and another year it's, oh shoot, we missed it this year. It's only 35% effective. That means effective in preventing you from getting it, but they all help your body to not have as bad side effects, so you can actually, and you're not fighting, you can overcome the virus a lot quicker, even if you do get the flu. So it still helps you. It's like, it still equips you with soldiers that can still help fight off the flu quicker, even if it's not necessarily stopping you from fully getting it. Yeah.
And we've been talking a lot about the COVID vaccine booster shot versus the COVID vaccine. So what is the difference between the vaccines I've received already and the booster shot?
Well, right now with the COVID vaccine booster shot that they have, it's the same vaccine. It's just making sure that you have a lot higher antibody levels in your body, right? So it's ensuring that you got a lot more soldiers if you come in contact with the virus, right? And as you've probably heard in some of the news with one of the just recent news with the new Omicron strain, that if it does, they're still trying to determine if it does evade the current vaccine. If it does, that means we just have to design a new vaccine. But more likely, it still helps us. The current booster will still help us to at least fight off COVID symptoms a lot quicker. Probably so we wouldn't require an ICU visit or some more severe symptoms. It still most likely will still help us to fight it off quicker. So getting a booster even to that strain, whereas it's been proven to help against the Delta, even that one. Like it was the original, our current vaccine for COVID was designed against the first strain, but it still helps against a lot of variants, which is great in COVID. It's a little more finicky for the flu sometimes, but with COVID, it's actually had some good cross immunity, which is phenomenal. So.
Okay, thank you. Pregnant women. Is it safe for pregnant women to get the flu shot?
Yes, you still should get the flu shot. It is not, it's not a live vaccine. It's like dead virus, chopped up virus. And the issue with pregnancy is that our immune systems are a little weaker during pregnancy. And that's why it's even more important to get protection, right? So it's even more critical you get the COVID shot or the flu shot during pregnancy, because you're more likely to get more severe symptoms if you do get the disease, the virus.
So I have a question for you. It's sort of a rumor that's been floating around, and I know I sent you these questions, and then you were sort of a little taken aback because this isn't a rumor that you had heard that I've heard a lot of. So I just want to get it out there and have you tell us the truth. So there's a lot of talk about the COVID vaccine containing fetal cells. Is this true?
No, it's false. And there's a lot of, unfortunately, especially with social media, there's a lot of fake information out there. And a lot of it has to be spawned by fear, right? Individuals who are fear or anti-vaxxers, they don't understand the science. And because of it, they'll try to make information fit to try to be a reason why they shouldn't take it, right? Because and I encourage everyone to talk to reputable sources and doctors and scientists and obviously C.A.R.P. to find out the real information. So it spawns from that originally viruses were created from embryonic tissues, human embryonic tissue back in the 1960s, right? The truth is viruses are tiny and they're not living. They have to grow in cells, in animals or organism cells. And the COVID virus is actually like a billionth the size of a human cell. So it's a tiny little balloon coming off the sun. It's ridiculously small. So they have to grow in like either bacteria or a human cell. You have to culture it, even to get the dead plasmids that our body would use to fight off these viruses. But since the 1960s, technology has been amazing, improvements. Like, as you know, the flu shot is grown in an egg. And that's where we harvest the virus out of cells of an egg, and we kind of, they distill it down and they get it out of it. So that's why there's not as much egg allergies. It's grown in an egg, but it doesn't include egg protein. Right. Well, with COVID-19, it's grown in a bacteria, actually. And they harvest the plasmids that we then inject in our cells. It's just a little genetic sequence that tells us to make one protein of the virus with a plasmid around it, and that's what's injected into us. It's pretty cool technology, but that's it does not come from dead fetuses or embryos. No, back about 50, 60 years ago, it did for some viruses.
Thank you. Thank you so much, because I needed to get that out there. So my last question for you is an audience question. So Maureen from Winnipeg asks, so there was a benefit in delaying her second COVID dose until 8 weeks after the first. Is there any benefit in delaying the COVID booster shot for more than 6 months after her second dose, or should we get it as soon as she hits that 6-month mark?
Well, that's where we need a little more information. They're not sharing us with all the information from these studies, unfortunately. So, but the benefit from the second dose 2 months after the first one is to allow that second dose to last a little bit longer until we need a booster, is kind of the idea, right? So when that second dose weans, like, the flu shot shows to wean at 6 months, right? That information, it'd be great if they shared more on that, but it's like how much it weans. It's what they're doing is trying to find out the average for the entire population when everyone needs that booster. And I think they've determined at 6 months, your original 2 doses, the antibodies we have to protect us start to diminish. So that's a good time to start getting your boosters. So at the 6-month mark, I wouldn't think it's any beneficial, but at the 2-week versus 2 months, that was a benefit for sure. To wait a little longer, so it just lasts longer in our body.
Great, thank you. So that is all I have for you, and you've definitely shone a lot of light on the science behind the flu and COVID vaccine. So thank you so much for joining us today, Andy.
Thank you so much. It was a pleasure.
Thanks. Have a great day.
You too.
Our next speaker is Timothy Caulfield, a Canada Research Chair in Health Law and Policy, and a professor in the Faculty of Law and the School of Public Health, and Research Director of the Health Law Institute at the University of Alberta. Timothy is also the host of the TV series, A User's Guide to Cheating Death. Welcome, Timothy.
Thanks for having me on.
Thank you for joining me today. I'm actually really excited about our interview because when I was going through all of the questions, I was like, these are the things that I keep hearing, and I know you'll be able to help debunk a lot of the sort of rumors and misinformation that's floating around out there. So you really talk a lot about vaccines, vaccine hesitancy, and the media, and how do we know what the truth actually is. So before we start to dive into a lot of this, I wanted to ask you, how do you define someone who is vaccine hesitant?
Yeah, that's a great question, because I think we need to always remind ourselves that not everyone is a hardcore denier, right? I think we have this perception that those who aren't getting the vaccine are, very, very adamant, or perhaps they're doing it for ideological reasons. That isn't always the case. People reside on a continuum, and there are those individuals that just have questions, or there might be driven by fear, as your previous speakers have noted, and they just want more credible information. That's one side of the continuum. And then on the other side of the continuum, there are those that are, I would say, hardcore deniers, very hard to change their minds, very hard to, get to them in a way that will turn their opinion around. And research tells us that, by the way. So I think of the hesitant, and I'm an optimist, so I like to believe that more people reside in this camp. I think of the hesitant as those that, for various reasons, are looking for answers and are hesitating to get their vaccines for a variety of reasons. And sometimes it's based on misinformation, but not always.
Right. And so when we talk about misinformation, we live in an era where there's so much information flying at us from so many different places, be it the conventional news, Twitter, YouTube. And this is a hard question to answer, but how do you start to tease out what is actual factual information and what is just garbage information? For use of a better word.
You want to go to trusted sources. I know that's a sort of an obvious response. And some people might not trust sort of the conventional sources like the Public Health Agency of Canada, like your provincial public health entities, like the CDC. Yeah. But the reality is you do want to start with those sources. The other thing you want to do is you want to ask yourself, what kind of evidence is being used to support the claim? Is this just someone's opinion? Is this just an anecdote? Anecdotes have become very powerful right now. They're very persuasive. A story can be very convincing, but you have to remind yourself that's not good data, right? Just because someone claims they had an adverse effect, for example, we don't know if that is really attached to the vaccine. So always ask yourself, is this a trusted source? What kind of evidence is actually being used? And the other thing you can do is you can fact check, just do a quick fact check to see what other sort of websites are saying about, other experts are saying about this topic. If it was something big, we would know, and we'd have credible information to back that up. Real quick, I think it's important to recognize the interesting research by my colleague Gordon Pennycook and his colleagues has found that most Canadians, most people, they want to be accurate. Over 80% of people recognize that we're on social media, that you want to be accurate. And so if we can just nudge people to remember that, we can make a big difference.
And so I'm going to read you some of the vaccine rumors that have been floating around out there. And you might have some of your own that you'd like to throw into this, but I wanted to do a bit of a speed round with you where you tell me if this rumor is A, true or false, and why. So the first, and this is one of my favorites because I hear it all the time, is that vaccines, specifically the COVID-19 vaccine, make you infertile and is all part of a population control plan.
Yeah,
I can't even say this seriously.
There's no evidence to support that at all. And it's not even scientifically plausible. There's no scientific reason to think that the vaccines would have this impact. And we've had a lot of both scientific entities and professional entities make it clear that there is no evidence to support this. So whether you're talking about the CDC, the World Health Organization, and Public Health Agency of Canada, or clinical entities like the Society for Gynecology and Obstetrics in Canada, they've made it clear that there is no evidence to support this. But I think this is a really important one. I know this is supposed to be a speed round. I apologize.
No, it's fine. We have time.
But it's an important one.
It is.
Because especially for young adults, for parents, right? There is the sort of the softer version of that, right? It's unknown that it will have an impact on fertility. And we've seen anti-vaxxers roll that claim out a lot just to create, I call it doubt mongering, just to create a little bit of doubt. So when you're doing that sort of risk benefit calculus and you're a young adult, and you say, why should I get the vaccine? I'm young and I'm healthy. Research tells us that this doubt mongering can have a real impact. So I think it's really important to debunk it in total.
Right. Thank you. So the next one, and I've heard this about both the vaccines and the COVID test, although I've had COVID tests and I don't even know how this would be possible, but the COVID-19 vaccine will change your DNA.
Again, no. And again, not even scientifically plausible. I think that this one was rolled out early days. And again, it has had a big impact. They've done studies that have shown that a lot of people actually do believe this, or they're not sure about it, right? So yeah, no evidence to support this at all. In fact, this is one that is so scientifically implausible that, you don't even really do research on it. It's like, do flying carpets work kind of question, right? So there's no evidence to support it at all.
I mean, the thought of it is kind of exciting because it's like, what would it do to my DNA? Will it make me smarter? Maybe this is a positive. No, I'm kidding. So the next one that I have is that the COVID-19 vaccine was created too quickly.
Yeah, this one is interesting. And again, a very powerful anti-vax message, right? A narrative. I'll put it. It's a very powerful anti-vax narrative. This isn't true either. No scientific steps were skipped. Right. The reason it was created so quickly is because there was a massive international effort, right? I think we should really view this like a moon landing, right? It really was an exciting, incredibly successful scientific initiative that saw collaboration internationally, collaboration between the private sector and research institutions, universities, and that's why it was done so quickly. In addition to that, there were a lot of individuals involved in clinical trials. Just building a clinical trial can take a long time when you're not in the middle of a pandemic. Here, they were able to create clinical trials and do them very, very well and in a very robust manner. And in addition to that, I think it's important to recognize that now we've had, I think, over billions of people have received this vaccine now, right? And you're looking at we have this post surveillance going on all over the world. So we have so much data now. To call this as experimental is absurd.
Thank you. And the next question, and it's more sort of, or the next rumor, and it's more sort of about COVID overall, was that COVID was created as a plan for, insert your conspiracy theory here, and all of this is planned. So what do you say to that rumor?
Yeah, I hear that. I hear it almost daily, right? And this is interesting because it really highlights how long-standing conspiracy theories have been sort of morphed to fit the current situation, right?
Right.
So these are conspiracy theories, this idea, and sometimes they're anti-Semitic, right? That the idea that there's this star chamber that is, manipulating world events for a particular purpose. Obviously no evidence to support that. I don't have to say that, but I do think there's also a soft version of this kind of conspiracy theory, the idea that, it was a bioweapon. Yes, we still have to investigate where this came from. Might have been a lab leak. The evidence now tells us it was still probably most likely, a natural occurrence. Or the idea that particular politicians are manipulating the narrative, whether it was created or not, but manipulating the narrative to impact things like the market or impact elections. Again, no evidence to support that at all. And if I could, I also think it's really ironic that the exact same people that say the governments are incompetent and can't be trusted somehow believe that they're incredibly competent at creating this fantastically sophisticated conspiracy and keeping it 100% secret. So they're both incompetent and fantastically competent. It's, I don't know, mental gymnastics, Olympic level mental gymnastics.
Yeah, it's pretty impressive. And I always think to myself, like, if I was at the top of the world and one of the elites, is this what I would be doing in my free time? And I don't feel like that is what I would be doing, but thank you for also debunking that rumor. I remember watching the documentary Social Network, and one of the things that really stuck out to me was that we as a society can no longer agree on what the truth is. And I think we're seeing that come out over and over again during this pandemic. So when we look at the effects of this pandemic, and if you had a crystal ball, like, what are some of the learnings that you hope come out of this? And also, do you think we're ever going to get to a point where we'll be able as a society to come back together and agree on what the truth is? Because I feel like it's been lost.
Yeah, you're so right. And we know that social media is a huge part of this story, and that it's stressing us out. Is that right? It's stressing us out. We know that. And there's, again, a growing body of evidence that tells us that. There's an interesting study actually from University of Alberta that found that 85% of the misinformation that is out there had as its origin social media. So I think one of the big takeaways is the power of social media. I think that we're really starting to learn that and appreciate it. And I think there's also a bigger takeaway, and that's just about misinformation. You know, I've been studying it for decades, and I've never seen it like it now. I mean, it really is a mess. It really is chaos out there. But the good news is there's this growing recognition, right, that misinformation is a problem. And I think that people now recognize that it is one of the great challenges of our time. So you have international entities, national entities, regional entities, you have professional organizations, you have research institutions. Everyone recognizes that this is a severe problem and something needs to happen. So that's good news, but it's not a battle that's going to be won easily. I think it's something that is going to go on and on. To your last point, we're always going to be, fighting and negotiating with this chaotic information environment in order to ensure that good evidence rises to the top.
So when we talk about good evidence and misinformation, in my own educational background, I have an honors degree in molecular biology and biochemistry, and I work in primary health care, but I still lean on actual experts to tell me about vaccines and how they will affect me. So how do you deal with the I did my own research crowd? Because to me, I don't even feel comfortable doing my own research. And I know there's a lot of people who have less understanding of science than I do who are claiming I did my own research, and that's why I don't believe I need any of this. So how do you counter that? How do you even talk to that?
Yeah, it is frustrating. And what's interesting is that phrase, or I'm just asking questions. I don't know if you've heard, that's another strategy.
I question everything.
I put that also in the camp of doubt mongering, right? They just trying to constantly inject doubt. The goal here, I know you know this, but the goal here is just to create chaos, right? Often they just want the noise to be out there. And so one of the things I do, and I bet you do this also, is, remind people to think big picture. Always think about the big picture, the big knowns that we have out there. Always think about the scientific consensus and the body of evidence. And we know these vaccines work. We know they work fantastically well. That's the big message, right? That's the big message. Don't allow people to pull you down into the vortex of conflict, right? Remember the big picture. And the other good news is debunking does work. It may not feel like it, but research tells us that debunking works. So giving people a path to credible information can make a difference. It may not feel like it at first, no one changes their mind right in front of you, right? But if you give them that path, long term, we really can make a difference.
Yeah, and I do try that, but I'll be in an emergency room and then know that they had this many admits of COVID patients that day, but then I'll tell that to someone who is a complete disbeliever and they're like, that's not true. I'm like, but I literally saw it and I know it's true. So to me, I feel like there's a group of people who I can sort of try and help, but then I feel like there's a lot who I just I can't bang my head against the wall.
I think that's important. You want to pick your battles, right?
Yeah.
You do want to pick your battles, and you want to know when it's appropriate to walk away. But I always like to be a glass half full person, and I think long term we can make a difference. And the research tells us that these conversations, these one-on-one conversations, be empathetic. You listen. You tell your story, right? And you give them a path to credible information, and we can make a difference.
Well, thank you so much, Timothy. This was an amazing conversation. I'm happy that you've helped to debunk so many of the rumors that are out there, and it was a pleasure speaking with you today.
Thanks so much. Take care, guys.
Thank you. We'll be back after this short break to talk about vaccinations across the lifespan, including pneumonia and shingles, and answer your questions about the COVID vaccine and booster shot. See you soon.
the sort of patterns we saw last year, no flu at all, they're not going to stay because we can't sort of tolerate these lockdowns forever. For things like shingles vaccine, I mean, this is meant to prevent shingles, which anybody can get if they had chickenpox when they're younger, which is pretty much most people. But I mean, at the end of the day, we haven't seen so many of these infectious diseases because of these lockdowns, but that's going to change. And if we don't get people vaccinated, then we're just going to have more and more of these other things, right? We talk about measles as an example. Nobody likes a measles outbreak. And, you know, everything's fallen by quite a lot, right? Upwards of, depending on the vaccine, 25 to 90%.
So I think one thing that you can probably agree with as a healthcare worker is that the COVID-19 vaccine process has been an uphill battle. So is there anything that you think we've learned from this process that we could now apply to routine adult immunizations? And like, is there a heightened awareness now? And like, what are some things that we could do to make the world better?
Yeah, definitely. So, I mean, I think there's certainly a heightened awareness and interest, right? I mean, I don't think vaccines were particularly sexy as a topic before COVID. And that's probably because they were doing the jobs really well. We don't see a lot of these infections that, you know, probably our parents or grandparents live with. Certainly a lot more awareness, but, you know, we have to translate that awareness into access and actual uptake. And, you know, when I think about that, through COVID, we've built certain systems that will enable all sorts of vaccination. Pharmacists, for example, have done a wonderful job administering the COVID vaccine. They do most of it. And I think pharmacists are an excellent channel to deliver other vaccines, particularly adult vaccinations. All the provinces, too, have generally had to build data systems. So, you know, instead of tracking your vaccines in the little yellow card in Ontario, it's in a computer system. So public health has been dragged into, I don't know, the 20th century, 21st century. And so these things are all things that we can build upon. And so it's mostly been bad, but I think there's a lot of tailwinds to make things better in the years to come.
That's actually a good talking point. The vaccine passport isn't just here to sort of track where you are. It's healthcare welcoming technology, which, as anyone who works in healthcare knows, is something we've been waiting for so long. So my next question is, so like I told the previous speaker, I'm not going to say how old I am, but and my age, how do I know, or how do I find out what vaccines do I need for my life stage? So how does someone who is 65 or 50 or 20 know what vaccines they need so that they can ensure they're up to date?
Yeah, so I mean, there's a lot of sources you can go to. I mean, usually if you just Google adult immunization schedule Ontario or Alberta or whatever, like that's usually a really fast way to do it. And you'll be led to the ministry websites. I mean, NACI has this information. You can ask your doctor, you can ask your pharmacist. But, you know, it's not too complex for older adults, right? I mean, they should get a flu shot every year. They should get those pneumococcal vaccines. They should get the shingles vaccine. And for vaccines they may not have gotten when they were younger, like, let's say, a Hep B or a HPV vaccine, it's a lot easier for adults, actually, than infants, you know, who need to get vaccinated every 2 months with, like, 7 vaccines.
And so I want to switch gears a little bit. So our last speaker, we talked a lot about vaccine hesitancy and misinformation. And I know you've done some work to combat vaccine hesitancy in rural Alberta. So can you tell me a little bit about that and some of the things that you've done to help combat vaccine hesitancy?
Yeah, so I mean, I think when it comes to combating vaccine hesitancy, one of the biggest drivers, I think that there's some people, a very small number of people who are like kind of conspiratorial in thinking, like Bill Gates with microchips in, but most people, like 95% of the population, is not like that. And so in many ways, it comes down to trust, right? You know, I know a fair amount about vaccines, but even I don't know everything. And so I generally trust Health Canada. When it comes to other people, you know, if you have the trust of the community of the people you're interested in vaccinating, then that's sort of the way to go. And I think one thing that we've done a lot of has been working with different community groups, you know, in rural areas and urban areas as well, to sort of build that trust. Because oftentimes the messenger matters more than the message itself. So that's one key piece. The other thing that 19-0 has done a lot of is sort of what I'll call evidence-based marketing campaigns. And so, you know, I think that having worked in public health, worked for government, I don't think we're the best at communicating sometimes. Whereas I think, you know, a company like Coca-Cola, very good at marketing. And so we've pulled in a lot of marketing experts and, you know, fed them the data from the people of interest to build some of these campaigns that I think are hopefully a bit more compelling than sort of just say, get vaccinated.
Right. Yeah, and I think the trust and relationship piece is so important, and that sort of leads into my next question. So we've seen vaccine hesitancy and just COVID and the vaccines in general break up relationships and families, and people aren't even speaking anymore. And this is not what this should be doing. This is a time when, I mean, to sound cliche, we need to all be together. So how do you personally, or how do you recommend people combat vaccine hesitancy with people in your life so that you are still speaking to them next Tuesday?
Yeah, totally. I mean, I think it is really sad that this has happened. I mean, I generally start from the perspective that people who are getting vaccinated or aren't getting vaccinated are trying to do what's best for their own health, right? They may be a little bit misled. Like, I don't tend to, blame individuals for this. And so that starting point of empathy, I think, is really where you begin versus a position of judgment. And I think there's a lot of judgment from the pro-vaccine camp and also the anti-vaccine camp. But I think basically that, people will only listen to you if they think you care about them. And there's been too much, anti-rhetoric going both ways, particularly on social media. But the fact that you're talking to people means you have a relationship with them. And that's probably the single most important thing.
Great, thank you. And we have a question from our YouTube live feed. So Linda is asking, how do you deal with people who say that we won't know the long-term effects of mRNA vaccines until years from now? So why would I put this in my body if I don't know what the long-term effects are going to be?
Yeah, so I mean, these mRNA has been around for quite a long time. I would say that billions of people have gotten these vaccines. I could say that these vaccines, these type of vaccines are non-live vaccines, so they can't give you a disease, and no non-live vaccine and history vaccines ever created long-term side effects. And so those are all reasons why I'm pretty sure it'll be safe in the long run.
Sorry, can I just interrupt you? Can I just interrupt you for a second? So I just want to repeat what you said. So you said no vaccines in history have ever had long-term side effects. Is that what you said?
Yeah, non-live vaccines.
So no non-live vaccines have had. So I think that's important for people to hear because it's just important to hear.
Sure, yeah. But I mean, at the end of the day, when I frame any decision, it's always like risk-benefit, right? And, I can't say that these vaccines are 100% safe. Oh, yeah. Can you hear me?
Yeah. Sorry, my earpiece is falling out.
Oh, no worries.
You called me out.
Oh, sorry. When it comes to anything we do, getting vaccinated, any medical thing, it's always a risk-benefit calculation, right? And if I weigh the benefits of getting vaccine, the benefits are probably thousands, millions of times greater than the risks of it. We take risks driving to work every day, but we sort of think, oh, it's probably worth it. And so I think, especially as we go into winter, where we see more cases, especially with Omicron, which is way more infectious, the benefits just have always outweighed the risks for the COVID vaccine.
And so when we talk about misinformation, where do you recommend people go for credible information about vaccines?
Yeah, so I mean, there are so many credible sources. I mean, any government website is going to be credible. Most mainstream, if you want something a bit less dense, like the Globe and Mail, the New York Times, they have all these explainers. Those are all very, very accurate, I think. Places to not go, I think, are Facebook groups, WhatsApp chats with their relatives, because they aren't sort of vetted at all. But there's an abundance of credible information actually out there. And so any public health website, government website, or mainstream media source, they're always generally on point.
Wonderful, thank you. And I just want to switch gears a little bit to ask you a question about pneumonia. And so why should everyone over the age of 65 get the pneumococcal polysaccharide vaccine? Why is this important?
Yeah, I mean, pneumococcal disease, this vaccine prevents against this bacteria. It can give you pneumonia, but it's also called bloodstream infections, meningitis. Every year, many Canadians die of this, and the vaccine works pretty well against it. It's available, and it's kind of easy. You just get it once generally, and then you're covered for life. And, I think that, again, we have seen a decrease in pneumonia because people have been kind of just hanging out in their basements.
Right.
But, they're going to come storming right back. And, we want to prevent as much death as possible. And for a shot, it doesn't take that long to get. It's easy to get. It's free. It's a really good idea.
Great, thank you. And we had our audio cut out at the very beginning on our YouTube live feed. So I just want to circle back and ask you the first question again. So my question was, how has COVID-19 affected routine adult immunizations?
Yeah, so high level, it's decreased uptake, primarily because it's been hard to access the vaccines. That's bad. But it's been good because it really has created a heightened awareness around the importance of vaccinations. And vaccinations have been the single best public health intervention, medical intervention in the history of humanity. And so, I don't think people think about vaccines so much before COVID, but now everybody knows what antibodies and vaccines are, that's for sure.
Right.
And so we should get COVID, but also the other stuff.
Yes, thank you. And my last question for you also comes from our YouTube live feed. So Anne from our YouTube live feed asks, vaccines have saved millions of lives over history, so why the hesitancy now?
Yeah, I think what sort of happened is, before COVID, there was like this vaccine hesitancy movement. The WHO called it, one of the great top 10 public health threats of the world, but it was much sort of smaller. And what happened, I think, with COVID vaccine is it got quite politicized, right? And, I think that fed into the broader polarization we see across society. And, that becomes, when these become political issues, they shouldn't be, it's very sciencey, you get in trouble. That being said, I still end on a happy note. Canada's first dose uptake is around 90%, which is very similar to a lot of our pediatric vaccine uptake. And so we are in one of the best positions in the world. Of course, I'd love it to be 100%, but in spite of all the hesitancy floating out there, the vast majority of Canadians have gotten the vaccine, and there's been a lot of work by pretty much everybody inside to get us there. And so, yes, it's been a problem. Yes, I don't want this to stay as a problem, but Canada as a whole has done quite well.
It's true. Well, thank you, Dr. Hu. And you're not actually going anywhere because you will be joining us again at the end of the show with Dr. Gorfinkel to go through some more COVID-19 vaccine and booster questions. So thank you for speaking to me now, and I'll see you soon.
Thanks.
Thank
See you again.
Our next speaker is Dr. Iris Gorfinkel. Dr. Gorfinkel is a family physician who has participated in over 60 clinical trials with a special interest in vaccination research. She helped co-author seminal papers on Shingrix and has sat as a co-chair on the Shingrix Advisory Board. Welcome, Iris. I'm really having trouble saying Shingrix today. Shingrix.
Many thanks for having me back, Natasha. It's always a pleasure.
It is. I really appreciate our conversations. And as I said earlier with Dr. Hu, you'll be staying with us for this session and then for some more questions on COVID. So we'll be spending some time together.
Fantastic.
So, before we talk about COVID, though, I want to talk to you more about pneumonia and shingles. So my first question is, what are the vaccines that people should think about after they turn 50?
There's a whole list of them. And frankly, there's a lot of competition in the space when you go to a family doctor. So I'd suggest making an appointment specifically to talk about this. So most people are familiar with influenza. You need that every year. But what's forgotten? Pertussis. Remember that? Whooping cough? Well, guess what? There's close to 3,000 cases in a bad year in Canada. Anywhere between 1,000 and 3,000 cases, can break a rib. It's so bad. It starts out as a cold and turns into a horrible cough. So that's once in a lifetime. Of course, tetanus is every 10 years. So this is a whole appointment, actually. And then we talked about pneumococcal vaccinations. That's against pneumonia. And there's actually two floating around. One is called Prevnar 13, which is recommended to get first. And 8 weeks later, the Pneumovax 23. That's what's recommended. And then, of course, shingles vaccine is on that list. It's quite a long list of vaccines, but once they're checked off, they're done, and you don't have to keep thinking about it. Then if for travelers, hepatitis A and B, that's for most of the world, and of course, typhoid fever as well is on that list.
Great. And so when we look at the shingles vaccine, what is the efficacy of it, and how long are you protected for after you get the shingles vaccine?
Shingles vaccine was called, like the trials that looked at that, of which I was a part, was called the best trial in the past 10 years. That's how robust this data was. And I still remember when they made the announcement, it was 97% effective in reducing disease. That's tremendous. That's in individuals under the age of 69. When you're talking about over that age, it's still over 90% efficacy, some 91%. And what's exciting is that it not only reduces a common disease, it also reduces the result of that common disease, which is damage to the nerve called post-herpetic neuralgia. And that affects a large number of individuals who experience that. And so you have about a 90% reduction to the neuralgia that can come with having had shingles.
So you call shingles a common disease. So how common actually is it? Like, what are your chances of getting it once you've turned 50?
You know, it's interesting. The lifetime risk is 1 in 3. So as people age, they're more likely to get this disease. So it is, to say that it's common, what the vaccine does is it takes a common event and turns it into a rare event. That's why it was called one of the best research trials in the last decade, because it is taking such a common thing. And what are the chances that increase that? This is interesting. Physical and psychological stress both can increase the risk. And we've heard these risk factors before. They're the very same as with COVID. That entire list of common, chronic conditions, especially those that immunosuppress. Things like diabetes, that's an immunosuppressive condition. So it is important to get that vaccine on board. The problem is we've got spotty coverage. I think you were talking about that a bit earlier, and it's a pity. It is an expensive vaccine, and not every province will cover it.
Okay. Oh, okay. That's interesting to know. And so, is there an age where the shingles vaccine isn't as effective? So is there sort of a drop-off age where it doesn't matter if you get it or not?
This is a vaccine which is effective at all ages. The efficacy does drop in the very older patient, but it doesn't drop by a lot. So it drops by about 7 to 8%. So it goes from 97% to about 90%. But it's still important to get because it's the best we've got, which is to say it will take a common disease, a common event, 1 in 3 lifetime risk, and make it into a rare event. So that's why, I try to get all my patients to be vaccinated against that. Really, there's no excuse to have disease when we have such a vaccination in our armamentarium.
And that's a good way of putting it. You're getting vaccinated so you can turn a common event into a rare event. So I like.
And we can say the same thing for pneumococcal disease,
for
right?
Sure.
So there's no reason why one should have pneumonias. Now, true, people can get pneumonias for other reasons. There's viral pneumonia, there's even fungal pneumonia. But I think the key messaging here is this. Once a person has a pre-existing lung condition, whatever it is, it could be asthma, it could be a smoker's lung, that's hugely important. COPD, emphysema, all these things, they set the stage for other diseases. So once somebody has one underlying lung condition, they are on board for getting multiple other lung conditions. We heard the same song being sung when it came to COVID-19. It's the very same thing. You got a chronic heart condition? Well, guess what? The heart lives right next to the lungs. They're like this. So it is critical to be vaccinated.
And so does shingles only affect you if you've had chickenpox or not had chickenpox in the past? I always get confused between the two. So what is the link?
What shingles is a reactivation of the chickenpox virus. It's incredible. The virus can stay dormant literally for decades. And for some individuals, the virus, it's like a seed in planet Earth that only comes out 8 to 9 decades after. It can be a number of years, but the virus reactivates and it travels down the nerve root. And as it does, it's causing damage. That's the problem. So we can vaccinate to prevent that from happening. But yes, it is common, more common as people get older because of a depressing thing called immunosenescence, which we heard also for COVID-19. Our immune system just isn't as robust at recognizing and preventing these diseases from happening as time goes on.
So I have an audience question. So Maureen from Aurelia asks, I had the original shingles shot. Since then, there is a newer updated shot. Is it necessary for me to get this shot, or am I still protected with the older version?
You do have protection from the older version, but the recommendation across the board, no matter where you live, in Europe, in the United States, and in Canada, is get Shingrix. So if you had the old shot, Zostavax, it's just that it's less effective and it falls off with efficacy over time. So that's why everyone is still advised to get Shingrix, even if they've had Zostavax.
Okay, and so if you've actually had shingles but have not been vaccinated, how long should you wait after you've had shingles to then get vaccinated?
Great question. I get this all the time. So the lifetime risk, if somebody's had shingles, of getting it a second time sits at about 20%. So 1 in 5 individuals will still get it. You're not out of the woods. So there is not an exact time frame. In Canada, it's about 1 year. That's generally what we wait here. However, if you're living in the US, it can be given almost right away. Some say 2 months. But my thing is, like, I just try not to find an excuse not to give it. I just try to get it on board because I think that's the more important thing. But generally speaking, there will be immunity after someone has had it, but the immunity does not last a lifetime. So I would say a year is very reasonable.
And so switching gears a little bit from shingles to the pneumococcal vaccine, who should get the pneumococcal vaccine?
Yeah, so this is a complex question, actually, because this is not a one-size-fits-all. If somebody has any degree of immunosuppression, it should always be a consideration. And incidentally, the same is true for Shingrix. So if somebody is really immunosuppressed, Health Canada has already approved it for individuals 18 and over. So pneumococcal disease, like these diseases strike when the iron is hot, when people are less, are more vulnerable to it. And immunosuppression sets that stage. What about chronic liver disease? Severe obesity, like these are all risk factors, and the government actually does cover individuals to get vaccinated when they have these conditions, even at a younger age. But if you're just the average Joe with the average weight, with average no medical history and basically healthy, it's over 65. And what's recommended is you get 1 dose of Prevnar, and then 8 weeks later, you get the pneumovax vaccination.
So those are the 2 pneumococcal vaccines. So there's Prevnar and Pneumovax
23.
Pneumovax.
You don't have to know those.
Pneumovax. I might have to know this one day. It might be a question on a trivia game or something. So those are the 2 vaccines. So you just said you get one, and then the second one you get 8 weeks later.
Yes, that's correct. Now, what if you already had pneumovax? Then you're supposed to, weirdly enough, wait a year before you get the Prevnar 13.
Okay.
But your doctor can, like a person's doctor, can look at the vaccines. The key message, get these boxes checked off your healthcare list. This is low-lying fruit. Vaccination makes a lot of sense. Governments are covering it, generally speaking. And even if they're not covering it 100%, it's worth the out-of-pocket payment to make sure that you don't have a disease that's actually preventable through vaccination. And once they're checked off, you don't have to keep coming back to them.
It's true. So certainly the key message from our talk so far is talk to your doctor, see what vaccines you need, and get them. It seems like pretty simple advice. I do want to go back to one of the things you had talked about. So when you talked about the Shingrix clinical trials, you said they were seen as one of the most robust clinical trials ever. And so I'm not sure how familiar you are with the COVID-19 vaccine clinical trials, but in terms of being robust, like what is your opinion? Do you think, because you hear a lot of talk about the COVID-19 clinical trials not being very good, whatever that means. So as an actual health professional, what is your opinion on that statement?
They're very different vaccination trials. So you look at COVID-19, that was done at a time in which the world was in an emergency situation. The world was suffering a pandemic. We had to have data, and we had to have data very fast and furious. So basically, we were comparing the risks after about a year with those trials versus shingles vaccine. Those trials took 4 years to complete. And that's pretty typical of vaccination trials, and generally speaking, that's what made that data so robust. We had 4 years of data. And then on top of it, those trials are still continuing on now to try to better understand just how long the immunity will last. So it's funny, I'm a part of those trials, and we are aging along with the kind volunteers who were in that trial. It's amazing. But those original trials that Pfizer and Moderna are doing, they're still ongoing as well. Right. People don't realize it. They're still happening. But they had emergency use authorization early on because of the world pandemic.
Of course. Well, thank you. That helped clear things up. So we have a question from our YouTube live feed. So Andy asks, I've had 2 relatives who were not vaccinated against shingles, who then got the COVID-19 vaccine and got shingles right after. So is there any connection, or is this something you've heard of, or is it more of an anecdote?
That's an anecdote, but we have to look at big data to direct things. Bad things often happen, and they can happen randomly. So the only way to really understand that space is to compare how many people who had a placebo versus how many people had the active vaccine. That said, getting a vaccine is not always easy for people. Some people are going to get systemic side effects like headache, muscle aches, joint pain. So there is a bit of a challenge to the immune system. But does that mean they're more likely to get other diseases during that time? That takes a trial to really understand that space. So I can also tell you about patients who got the vaccine and were crying with joy because they knew they weren't going to get the disease, or their likelihood was far less. So what do you do with the one-off? It's hard to know. I mean, you have to look at that in terms of big data, and there has been no trials which have shown an increased risk of shingles after getting vaccinated to COVID, to my knowledge.
Okay, well, that does help. And for my last question to you, and this is something I've been asking most of our guests today, how do you combat vaccine hesitancy in your own life if there's someone, be it a patient or a loved one, who has questions and isn't sure and doesn't really want to get it because of what they're hearing? How do you combat that?
I try hard to understand the space. It's been an interesting evolution in my own life, because at one time I was like, there's the door. That's not what I do now. I'm just saying, I really was hard-lined about it because the data seemed so clear to me.
Right.
But the fact of the matter is, people bring on all kinds of reasons and stories, and I think my job is better to understand what they are so that I can meet them and try to talk to them about what the factors are that make them hesitate. So that's one aspect. Another aspect for so many people is just a matter of access. Get it to them, make it easy to access, and boom, they get it. A lot of people are worried about side effects, so we can talk about the short-term side effects. But you were mentioning, what about those years later something popping up? The vast majority of side effects in clinical research are picked up within those 3 months of having gotten the vaccine. So could there be something else in minor? Well, we know COVID-19 up front causes very significant and very serious harms. So those harms cannot be underestimated.
Right. Well, thank you so much. And you're not going anywhere. You'll be sticking with us. So I now have Dr. Jahu joining Dr. Iris Gorfinkel to answer your questions about the COVID-19 vaccine and booster shots. So thank you both for joining me. And I'm going to start with a heavy-hitting question. So I'll leave it to both of you to decide who's going to answer. Okay, so my first question is, and Dr. Gorfinkel, I'm going to direct this towards you. How many people has the vaccine killed so far in Canada?
Okay, which vaccine
are
we talking about?
The COVID-19 vaccine.
How many deaths have been associated with vaccination?
Yeah, from the COVID-19.
I'm not aware of any deaths associated with it. I am aware of significant outcomes from it, serious adverse events, but I'm not aware of any deaths that happen directly relating to the vaccination. So that if the fear is myocarditis, pericarditis, the risk is actually extremely low. The vast majority of individuals who do experience it have such minor disease you can't even pick it up on a heart ultrasound. It takes a heart MRI, and they get better after you give them a little bit of Tylenol or Advil. Right. So that's the vast majority. And so I think that, again, this always comes down to weighing it against the potential risks of the disease itself, which are very significant, include hospitalization and death.
And Dr. Hu, do you agree with the data? 0 deaths from the COVID-19 vaccine in Canada?
Yeah, there might be one or two from VIT from AstraZeneca, which is a vaccine we don't give anymore. But Dr. Gorfinkel's on point, right? And you got to compare that to what is it, 40,000 deaths from COVID? I mean, once again, you see tens of thousands of times benefit vis-a-vis the vaccine. With the mRNA vaccines, yeah, myocarditis with vaccines is transient. You recover quickly. I'm not aware of any deaths from the vaccines we currently give, that's for sure.
And so my next question is focused more on the booster shot. So does a 45-year-old need the booster shot?
Yes, I would say absolutely. Health Canada has now approved it for all individuals 18 and over. And what we're seeing is a broadening of the criteria that people qualify for. If we look at Israeli data, starting from month 3, vaccine efficacy starts to fall off. In my view, if anything, Health Canada needs to go back and revise its definition of what is fully vaccinated. Fully vaccinated is not 2 doses, it's 3. 0, 1, and 6 months. It's not the 2 doses that, initially we had thought it would be and hoped it would be.
And there was a fairly large study that came out of Israel that showed, and I might be misrepresenting everything that was in the study, but it showed that herd or natural immunity is supposed to be better than the vaccine, or that's how people have interpreted this study. So can you, I think Dr. Hu, you were smiling because I think you know the study I'm referring to. So can you speak to that?
I mean, I think it depends on the studies, but like at the end of the day, what you want, if you've been infected, you're given a lot more protection if you get vaccinated, right? When it comes to certainly earlier strains of COVID, vaccine-induced immunity generated a far more robust response than natural immunity. But like, this is kind of besides the point, right? Especially with Omicron around the corner. You may have heard in the news yesterday, a number of studies came out showing that a 2-dose series, just 2 vaccines against Omicron, produced about 25 to 40 times less antibodies. That's a big drop. But once people were given a 3rd dose of the mRNA vaccine, they had actually pretty good protection or similar protection to how a 2-dose series work against the other variants. The bottom line is, for sure, there's waning immunity, which we definitely are seeing all over the world, including in Canada. But with Omicron around the corner, you definitely aren't really protected fully until you have 3 doses. And right now, Health Canada, NACI, everybody over 18 should get a booster, like full stop, like end of story.
And so,
it's interesting. You mentioned herd immunity. I'm going to just interject
yes,
a little
please do.
A factoid here. We cannot even talk about herd immunity until the world is vaccinated. I'm talking low-income countries. We are chasing our own tail because as we try to vaccinate and hyper-vaccinate our population, what winds up happening is that low-income countries that simply do not have the access are having more cases, therefore more mutations, therefore more variants of concern. And it's just a matter of, Omicron poster child. That's what's going to happen. So it's a race not just to get boosters into the arms of Canadians, it's a race to get shots into the arms of low-income countries. Let's not kid ourselves. In Africa, only 1 in 10 has been vaccinated fully. It's a serious problem.
And so I want to hold that thought because I want to come back to it. But I want to go back to Omicron, or Omicron, which is what I've been saying in my head. Omicron, that makes more sense. So I have COVID media fatigue, so I haven't been reading as much about it because I'm just tired. But we've been hearing from some physicians that it's not as virulent as the other strains. How much do we know about it, and what's coming around the corner? And I'm scared to ask that, but what is coming around the corner?
Yeah, so I'll say.
Sorry, Dr. Hu.
Go ahead.
Yeah, so the latest, we heard from the South African Ministry last week that it's likely that Omicron is not more severe than Delta and maybe less severe than Delta, but that's sort of too early to tell. Probably, it's certainly considered more infectious, but the single most important thing is how much it evades the immune response either from vaccines or natural infection, right? So a less severe, highly infectious disease can rip through a population and lead to huge numbers of hospitalizations. And, we're really lucky actually with Omicron that it does seem that a 3-dose series will offer comparable protection. And so even if it's a little bit less severe, if enough people get it, there's still gonna be a lot of deaths. And so this again feeds into the importance of people getting boosted and just getting every vaccine that right now NACI, Health Canada, multiple governments, are recommending.
So I want to ask you both a question as healthcare providers, and as someone who also works in healthcare, this is something that I feel like I'm always talking to people about, but I always get the stats, well, only 0.1% of the population have died from COVID, so why are we so concerned? And I try and speak to them about what's happening in our hospitals because, to sound a little crass, dead people don't take up hospital beds, but a lot of other people do take up hospital beds. So can you speak to why we're concerned about COVID? Because I feel like that message keeps getting lost.
I think some of this, I want to push back a little bit on the statistics that you just gave. First, 1 in 1,000 children will be hospitalized, but the risk of hospitalization in an adult population you know, if you're talking Delta, is 10 to 15%.
That's a lot.
It's a lot higher.
Yeah.
You know, so what winds up happening is exactly what we've seen. And I don't even want to bore the audience because they know waiting times for other surgeries, waiting times for virtually every single medical service is pushed back. You know, so I used to have same-day appointments, no problem. Now I'm struggling. I'm working much longer hours. What about the labs? You got to make an appointment and it takes longer to get that. I'm talking about simple blood work. Let's talk about x-rays. What do you have to do? You have to call and you have to wait again for x-rays and ultrasounds because guess what? It all just goes right down. You know, so if hospital services are bunged up, where does it all go? It goes to the outpatient. That's where it goes. And then what winds up happening is doctors are working virtually, et cetera. So you wind up with long waiting lists on pretty much every service. And that's not acceptable because we started out with pretty long waiting lists to begin with, if I'm not mistaken.
We don't have enough paper for these waiting lists is what I'm thinking. So Dr. Hu, my next question is for you. Why should a fully, and it comes from Jeremy in the audience, why should a fully vaccinated person be more concerned about an interaction with an unvaccinated person versus a vaccinated person? So if I'm vaccinated, do I need to worry more about Tommy who's unvaccinated or Bill who's vaccinated?
Yeah, so I mean, I think certainly the vaccine does reduce transmission. You know, the exact amount it reduces, we're not sure, but it does reduce transmission. And so when you're interacting with unvaccinated people, you're, you know, generally at higher risk than if you're interacting with fully vaccinated people. And, you know, if you're fully vaccinated, I mean, the vaccines are very, very effective, but they're not 100%, nothing is. And so, you know, we see more and more of these breakthrough infections. That being said, I don't think we should necessarily just say, I'm never going to interact with an unvaccinated person. You know, it goes back to sort of this empathy piece, right? Where one, I think it's very normal and appropriate to inquire about somebody's vaccination status. And, you know, we all have our own sort of risk tolerances. We all have, you know, our own need to meet people. But yeah, it's certainly riskier. You're more likely to get it from an unvaccinated person than a vaccinated person, that's for sure. But, you know, don't stigmatize them. But yeah, be empathetic and, you know, learn about the perspective.
And also understand that at this point, we are dealing with a pandemic of the unvaccinated, period. Who are the people who are getting the disease? Who are the people who are winding up in hospitalizations? You take a look at some of Health Canada, the Public Health Agency of Canada's data, and they show you graphs that are really dramatic. So here's the number of individuals, like it's like this. The vaccinated are 98%. You know, the unvaccinated are 98% of the people who get the disease, who get hospitalized. You know, so that's a serious problem. And it's preventable.
So I do want to
ask preventable disease.
So I do want to ask a question about the vaccination, and I know, Dr. Hu, you want to say something. So about those who are ending up in the hospital. So it seems like those who are vaccinated who end up in hospital, and it doesn't say a lot about severity when I'm thinking about the stats I'm seeing. It's always hovering around 30%. But we also know that that was going to happen because no vaccine is 100% effective. So can you speak to that? Because there's also some misinformation floating around, or maybe it isn't, that there's more and more vaccinated people who are showing up in hospitals very sick. So is that true? What's happening? And I know you're going to talk about booster shots.
Yeah, you know, so I mean, one thing here, and this is like a little math fallacy, but you know, if everybody in the world was vaccinated and there was one unvaccinated person in the world, you'd have more vaccinated people getting COVID, like in terms of absolute numbers. That makes sense. And so you can't look at sort of the absolute numbers, especially as more and more people get vaccinated. You have to look at your likelihood of ending up in hospital if you're vaccinated versus your likelihood of ending up in hospital if you don't get vaccinated. And your likelihood of ending up in hospital if you're unvaccinated is 10 times, if not higher, than if you're vaccinated. And so, yeah, this is kind of one of these, like, what I call statistical fallacies. And yeah, again, vaccination works super, super, super well. The thing I was going to say, just to create a bit more fear, I don't know how much you guys follow Alberta medical news, but that's where I'm from. We had a pretty bad fourth wave. Our ICUs were at 300% capacity. Wow. That's pretty bad. We canceled every non-emergency surgery. So that means if you had a brain tumor, we wouldn't operate on you. And in that context, like, if it was an emergency, in that context, still 90% plus of people in the ICUs were unvaccinated. And as winter comes, as Omicron comes, I don't want that to happen to Alberta again or to any other province in Canada. And the only way we're going to stop that is by getting people fully vaccinated, including a booster. Includes kids too. But just, we have this wonderful thing and people really should take it.
So 90% of the people in the ICU were unvaccinated. I think that's an important stat to remember. So Dr. Gorfinkel, my next question comes from the audience. So Jerry from Toronto is asking, can you take the pneumonia vaccine and the COVID booster vaccine within 48 hours of each other?
What NACI has now said is that the vaccinations can be co-administered, especially the flu, along with the COVID-19 booster. My feeling is go ahead and get them. And, you know, they should just be given at once if that's going to serve as a barrier. Now, if it's not, you know, I could wait a week. I have no issues with that, or even a couple of weeks. But the key is to get them on board, because that's what matters most. These are common diseases, and we're trying to, you know, greatly reduce the likelihood of getting these common diseases. You know, it's interesting, we were talking about the hospitalizations and this effect. Nobody is saying these vaccinations are 100%. They're not. Breakthrough infections are going to occur. But what's interesting is when they do occur, the severity of the disease will likely be much less. And that's why we're also seeing, you know, the impact that it has on hospitalizations, on ICU, is unbelievable. Like, it really is. And it should absolutely not be taken for granted. Sure, it's not perfect. Could there be a breakthrough? Absolutely, there could be. But statistically, what we see, and this is real world data talking to us, and not just Canadian data, that the vast majority of hospitalizations in ICU is still, as we speak, are in people who are not vaccinated. They remain Canada's first priority to get the shot.
Yeah, so that, again, is important information for people to know, because there's a lot of information floating around. So my next question is also from the audience. So Jackie from Vancouver is asking, I have had surgery and radiation for cancer this year and am now on tamoxifen. Are there any reasons why I should not get the vaccines that we are discussing? I am triple vaccinated for COVID and have had the fluad shot.
Yeah, so she would be an ideal individual to get vaccinated against all of the above. And it's interesting, I always hear these questions, which is, I'm really sick. Should I get vaccinated? And the answer is, yes, you should get vaccinated against all these because you're really sick. Those are the individuals who get the worst disease.
Right. So my next question is also from our live feed. So Maureen is asking, there was a better immune response by having 8 weeks rather than 4 weeks between the first 2 doses. Is there a benefit to delaying the 3rd dose for longer than 6 months?
No, I mean, and here's the thing, right? Because what happened in Canada was that, you're right, we had to delay because we didn't have enough vaccine, and that made the immunity waned slower, but, you know, 1 dose is only partially protective. So there was more time at risk. And, you know, with Omicron, with winter coming, you should get this vaccine as soon as possible. Supply shortages will no longer exist. And I think that any time you're not fully vaccinated, including the booster, you are at higher risk than if you're not. So waiting for some theoretical higher overall immune response is not worth, you know, the higher risk you have when you're just not fully vaccinated when cases are rising.
Absolutely. And we know from Israeli data that the immune response actually starts to diminish after month 3. So it gets lower month 4, month 5, month 6, you know, and Canada has said, you know, 5 to 6 months after 168 days. Well, that's actually less than 6 months. And people are counting to the minute. I think that's absolutely ludicrous. And I really believe, heart and soul, we should not be delaying giving booster shots. You know, we should be pushing to try to get them into arms faster. We are in a bit of a race to make sure that people get that booster shot. And I don't see any benefit to waiting longer than 6 months, because we know from Israeli data that vaccine efficacy drops to about 45%. And you get that booster shot, 2 weeks later, you're back up to 95%. Right. So now we're talking mild to moderate disease. Luckily, 2 doses does continue to protect against hospitalization, but we don't even know those numbers for Omicron.
Right.
So, you know, it's going to take time for us to understand that data.
So we actually are done, but we're going to keep going, if that's okay, because we have so many questions coming in from our audience right now, which is why I have all these devices in front of me to get these questions. But we also have one. So Joe from Markham is asking, if a person had pericarditis after the 2nd mRNA shot, what is being advised regarding boosters? Does NACI have any clear guidelines on boosters after severe adverse reactions? And is any research being done in this area?
So I'm part of NACI, and we are currently discussing the recommendations around just this very topic. And so stay tuned, I guess, is what I'd say.
Okay.
Yeah,
so stay tuned. Okay. Well, that,
well, my understanding is if I had a patient who had pericarditis, the answer is no, I'm not going to give you that same shot. That's out of the question because you were really sick with it. And no, we don't have enough data to say what'll happen on the third shot. It seems to me if somebody had a really severe side effect, true, it's rare, but why would I give the same thing?
Right.
Would I consider giving something else? There is emerging data suggesting that may be a good thing to do because it diversifies our immune portfolio, but we'll have to keep our ear to the ground to see what NACI says.
Yes, and NACI's pretty fast, so I'm sure we'll hear something pretty quickly, right, Dr. Hu?
Hopefully. We're meeting a lot.
So our next question comes from Sharon from Vancouver. I have had both shots, Pfizer, and a mild case of COVID 10 days after the first shot. Is our immune system good for 1 year from the date of infection, or should I get my booster now? And her second shot was in June 2021.
Yeah, time to get that booster shot. Absolutely. According to Israeli data, your vaccine efficacy is sitting at about 45% to mild to moderate disease. What about to Omicron? Question mark, we don't know. The number I gave refers more to Delta. So that's why the race is on, because we figure you got to get the best immunity on board possible to fight not just Omicron, but other new variants that could be coming down the pipe.
Right. Which hopefully there isn't. I don't think we have any more Greek letters left, or do we? I don't know.
We got a lot more Greek
I know.
We can double up.
Sure, yeah.
I was hoping we didn't. I was hoping.
It's like postal codes.
No, stop it. So I have one last question to ask you both. And this is a question that I'm sure a lot of people are wondering. So I've had both AstraZeneca shots. I'm now eligible for my booster shot. My pharmacist says that there's no more AstraZeneca booster shots in Alberta, or there isn't any, and then told me that a mixed vaccine will not be acceptable for travel to the USA. So if I take my third booster shot now, then I'm told I'll need a fourth booster shot of that same vaccine in 8 weeks so that I can travel. Is that correct?
Yeah, I mean, I think that, first of all, I don't know if the U.S. accepts AstraZeneca, period, because it was never actually used in the United States. Yeah. And so, what you should get is an mRNA vaccine. That's the only booster. It's the recommended booster after a viral vector series like AstraZeneca. And you may need another mRNA vaccine after that. But, the best thing you can do right now is get that mRNA vaccine as soon as possible so you can get that second dose after that as soon as possible when it's available to you. Yeah. So get the mRNA. It works really well.
The short answer is yes, you will need your fourth. Thank you. So thank you both so much for joining me today. It was such an enjoyable conversation, and I know you've helped to dispel a lot of the rumors and provide a lot of information that people need. So thank you so much. Thank you.
Many thanks for having me.
Thank you.
Yeah, happy Thursday.
Thank you. Happy Thursday. So that wraps up today's program. Thank you for joining us. Please stick around to continue the conversation after the live stream ends. Local advocates from C.A.R.P chapters across Canada will lead live regional sessions to discuss the adult vaccination landscape in their communities and what steps individuals can take to advocate to politicians and policymakers to improve vaccine access for adults. You will be able to join a regional discussion once the live program ends. Thank you so much for joining us. Signing off from the Zoomerplex in Toronto, I'm Natasha Raey.